Good afternoon to all of you. I'm sorry there was a little bit of confusion with the topic I had to cover, so I will cover, I'm sorry, again, a little bit the ESC guideline on chronic coronary syndrome, which are important, are more patient-oriented. They suggest and to encourage adherence, and they consider, as you can see, different phenotypes, mainly based on pathophysiology. And you saw probably this possibility to really adhere more or make the patients to adhere more, even using digital opportunity. In terms of physiopathology, there is a recognition that not all angina are the same, and that is important. And ischemia can be due to epicardial stenosis, vasospasm, either selective or hyperimposed, and microvascular dysfunction. And this is important because each condition should have a specific diagnosis and a specific treatment. As for the diagnosis, there are some innovative 4 steps. Dyspnea is considered an equivalent to ischemia, and the estimation is linked to the likelihood and to the symptom characteristic of the patients. There is more imaging, either functional or anatomical, and much less exercise testing. And there is a huge menu for the diagnosis. And this huge menu is very important because you should not only diagnose angina, but also the reason for that particular angina. And so it goes from tomography to functional imaging, either with PET, CFR, or stress echo. And this is rather complex. Now, diagnosis is a focus on the underlying physiopathology, and that is the important message. There is improved algorithmic for the likelihood of obstructive coronary artery disease, and there is a lot on the evaluation of microvascular angina, either ANOCA or INOCA, using CFR, IMR, HMR, or acetylcholine if is endothelial dependent, the microvascular abnormalities. There is an evaluation of epicardial or microvascular vasospasm by acetylcholine. And you may ask, is this very important? Should I do this in all my patients? Obviously, it's very difficult. In essential, it is really important because remember that even when you do an angioplasty, you do something which will not improve the life of your patient. So you need to be sure of what you are doing. And also keep in mind that if you don't have all this capacity, it is always important to talk with the patients because the anamnesis can tell you really a lot. In terms of treatment, of course, early as possible, of course, lifestyle optimization, reduction of risk factor, easy to say, difficult to do. There is, and this is very important, an upgrade of ACE inhibitor to improve endothelial dysfunction and particularly perindopril, in my opinion, the use of GLP-1 inhibitors and the GLP-1 activators and the anti-inflammatory agents to prevent event prevention. Of course, medical therapy for thrombus prevention, we heard a lot about that. And yes, after 7 years that Professor Rosano and myself put it together, this diamond approach, the guidelines decided to use it. And I'm biased, of course, but I think it was a very good idea. However, the original diamond approach is based on the result of a systematic review of all the drugs which has been used during the last 50 years in angina. And the conclusion were no evidence that one drug is superior to another. The equivalence was demonstrated only for beta blockers, calcium antagonists, and ivabradine, And the newer agent, which normally are considered the second line, they do have more data than the older one, which are considered the first line. So the spirit of the diamond approach was, and still is, that all anti-anginal drugs are equally effective. No class is superior to the other. Therefore, the diamond approach excludes any categorization in absence of proper evidence, which at the moment does not exist. And yet, these guidelines are categorizing, and they're telling you you should start with the beta blocker. And if the beta blocker is not enough, add a calcium antagonist. Fine, but where are the evidence? Actually, addition of anti-antagonists to beta blockers does not improve anything. Then there is an upregulation of long-acting nitrates without any supporting data. Actually, there is evidence for the opposite, and the fact that nitrates are good in short time does not mean they're particularly good in long time. Then there is ivabradine only in patients with an ejection fraction below 30 or with heart failure. And that was done to align with the American guidelines. Fine. And this is indeed right. And there is a stronger support. But there is also a but. Why stronger support? Because if you look at the beautiful trial in a patient with angina, and in particular in those with heart rate above 70 beats per minute, there was an improvement of the primary endpoint of cardiovascular death and hospitalization for angina. And look at the difference in those patients with a heart rate above 70 beats per minute in terms of need of revascularization. But those are beautiful are not the only data to support the use of ivabradine in patients with a reduced ejection fraction. Also the data from SHIFT with overt heart failure in those patients in a pre-specified subgroups who had angina, there was an improvement of prognosis. But this is okay, but remember that ivabradine works also in patients with preserved ejection fraction. And we do have evidence from 12,000 patients, not only one. And also we have evidence that if you add ivabradine to beta blockers, you have a better symptom release. And all these drugs which are considered for ANOCA and INOCA have never been tested on the basis of microvascular activity. So it is not clear to me why beta blockers are considered to be the first line. Could, for instance, be better to use ivabradine and or trimetazidine in these patients with the microvascular angina. So my conclusion, these guidelines are good. And is a huge 120-30 pages comprehensive document. There is a clear improvement from the previous guidelines. Several innovations in terms of pathophysiology and phenotyping, innovative and up-to-date diagnostic approach, no question about that. Excellent schemes, including the diamond, although the philosophy of the diamond approach has not been fully understood yet. Maybe they need a little bit more time. But excellent schemes, and that is very important. And this is one of the schemes that I like more. Consider when you are having a plug or something, what there is behind it. Thank you very much.
Excellent. Thank you very much.